Good afternoon. I am Peerapat Lertwiram from Ramatipidi Hospital, and it's an honor to present to you today on the topic that lies at our heart of in sport medicine practice, the strategies to prevent osteoarthritis progression. Now, here's a quick overview of what we are going to talk today. Okay, first, OA affects over 500 million globally, with knee OA being the most prevalent. When conservative treatment is failed, guidelines recommend joint replacement, which is not a cure, and many experience no improvement even after the surgery. To address the osteoarthritis effectively, we need to understand its causes. This slide provides an overview of the factors that involve in OA pathogenesis, including age-related factors, low-grade inflammations, metabolic alterations, and the last one is environmental factor. By understanding this, we can develop targeted prevention strategies. Now, let's start by the intrinsic factors. As we age, our bodies change, and our joints are no exception. The cellular senescence, inflammation, alteration in intracellular matrix, and the mitochondrial dysfunction. These alterations can cause metabolic alterations and reprogramming within joint tissues, fueling inflammations and cartilage degeneration. And finally, our environment, broadly defined, encompasses diet, exercise habits, occupational demands, and even genetics. These factors interact to influence OA development. Our genes can also make us more or less susceptible to environmental effects. Lifestyle choices like work or sports can also influence joint load and stress. Now, let's consider the osteoarthritis continuum. It provides a framework for understanding OA stages and guiding prevention. From the pre-disease to early stage and then late stage, each phase presents interventional opportunities. With that in mind, let's delve into prevention strategies. We can categorize them into primary, secondary, and tertiary prevention. The primary preventions reduce modifiable risk factors. Secondaries aim to detect and intervene early. The last one, tertiary, manages the consequences of established OA. Looking ahead, how can we forecast the development of osteoarthritis in people who currently show no signs of the disease? What are the subtle clues or even the early indicators that could help us to predict who will eventually succumb to this condition? Starting with the primary prevention, we'll look at the proactively reducing at risk of developing OA. This table outlines modifiable and non-modifiable risk factors for knee OA. By promoting healthy lifestyles and mitigating risk factors, we can potentially prevent OA. One significant modifiable risk factor is the obesities. To understanding this further, let's delve deeper into the obesities and OA, highlighting the macroinflammations and metaflammation. Macroinflammation is the inflammations caused by mechanical stress, while the metaflammation is caused by the metabolic alterations. So the obesity leads to both, creating a vicious cycle, accelerating the OA progression. There are many studies investigated how changes in the BMI during the middle age affects the risk of symptomatic OA. And BMI was also associated with a significantly increased risk of need of joint replacement. It highlights weight loss's impacts on OA. Studies show that even moderate weight loss significantly lower knee OA incidence rates. Encouragingly, findings demonstrate the higher adherence leads to lower incidence of knee OA. So, how can we address this? It highlights the challenges of maintaining weight loss and discusses approaches like dietary restrictions, exercise, and cognitive behavioral therapy, or even bariatric surgery. This emphasizes the need of multifaceted approach. However, we must acknowledge the challenge of the weight regain after weight loss, such as reduced dietary disinhibition, depression, decreased physical activities, and dietary changes. Understanding these could help develop strategies for maintaining weight loss. Now, moving on from obesities, let's consider joint trauma, particularly intra-articular fracture, significantly increases the risk of post-traumatic osteoarthritis, or what we call PTOA. Mitochondrial dysfunctions after the chondral injury will trigger the pro-inflammatory cytokine and chondrocyte apoptosis, which is affected more than chondral remodeling. Similarly, the joint instability from the ligament injury can also lead to PTOA. And due to the instability, repeated load of the subchondral bone will cause the more bone remodeling and subchondral bone cyst, which is more affected than cartilage injury. To put this together into our perspective, let's look at the risk factors of the post-traumatic OA. This table summarizes findings on the link between the knee injuries and OA risk. Certain injuries like ACL and meniscal tears are associated with the significantly higher risk. Therefore, preventing joint injury is the key for OA prevention. For example, exercise programs with neuromuscular control and strengthening exercise could reduce the knee injury risk. And this analysis highlights the effectiveness of the injury prevention programs in reducing ACL injury incidents. But what if an injury occurs? Even after, we can take steps to prevent our slow OA progression. For example, preventing re-injury and engaging in activities that promote joint health and preserve articular tissue integrities. Similarly, optimize the articular inflammations and minimize total body adiposities may also slow inflammatory process. And finally, addressing movement adaptation, muscle function, and weight gain may promote normal joint loading. In addition to injuries, occupational and sports overload contribute to OA development as well. This slide highlights the importance of balancing activities and rest. Both a sedentary lifestyle and high-intensity running increase the risk of hip and knee OA. Suggesting a balanced approach is a key. Now, let's shift to focus to the secondary prevention, which is very, very important. This involves identifying symptomatic patients with normal radiographic findings. Early-stage OA knee could present a window of opportunity using the biomarkers, including molecular and imaging tools in which to arrest the disease process at the early stage and restore the joint homeostasis. However, defining and classifying early-stage OA is very, very challenging. Ongoing research focuses on developing validated criteria and tools for diagnosis and classification. Actually, there are some classification systems for knee OA, but not being validated yet, like the rheumatoid arthritis or SLE. For molecular biomarkers, these studies found a combination of specific biomarkers, such as urine CTX2, serum HA, or even serum NCX1, to be the most predictive model for identifying at-risk individuals. Along with the biomarkers, the MRI is crucial in secondary prevention, allowing visualizations for early cartilage changes and structural abnormalities. However, limitations exist in distinguishing normal aging from the pathological changes, and further research is needed. This slide ultimately illustrates the importance of early detections in intervention. It emphasizes that the early OA detections improve chances of slowing progression and preventing damage, reinforcing the needs of effective secondary prevention. But if validated biomarker were used for everyone at risk without any symptoms, it would be over-diagnosis and over-treatment. Now, let's turn our attention to the tertiary prevention, focusing on managing consequences of the established OA to improve functions and quality of life. It includes lifestyle modification, physical therapy, pharmacological treatment, and interventions like joint replacement. This slide outlines recommendations from ESEO and OARSI guidelines for OA management. The core treatment and first-line therapy are the same. However, the glucosamine sulfate and chondroitin sulfate are controversial between these studies. In addition, the American College of Rheumatology in 2019 guidelines also offer the recommendations of various treatments. The glucosamine sulfate and chondroitin sulfate, as well as the intraarticular HA injection, PRP, and the stem cell injection are strongly recommended against. Furthermore, the American Academy of Orthopedic Surgeons, or AAOS 2021 recommendations There are a wide range of interventions that is recommended. However, those treatments are not yet recommended by the ACR, remain unclear or uncertain in WAOS 2021. Evidence regarding the use of glucosamine and chondrogen sulfates remain inconclusive, with 2 meta-analyses yielding conflicting results. Further larger-scale studies may be necessary to resolve these differences and provide clearer insights. Regarding intra-articular HA injection, the meta-analysis of 24 RCT with a total of about 9,000 people found that although intra-articular injections may lead to greater reduction in pain score, it may still fall short of MCID. Looking ahead, regenerative medicine holds promise for the OA treatment. For example, PRP or platelet-rich plasma that were thought to be an effective strategy to relieve the patient's symptoms and may involve with the cartilage regeneration. However, there are many evidences against these hypotheses. This slide discusses the potential of mesenchymal stem cells in OA treatment, which are reflected in chondrogenic characteristic, anti-inflammatory effect, and the role of mesenchymal stem cells in extracellular vesicle excretion. According to the meta-analysis, mesenchymal stem cells have shown promising results in the pain reduction for the short term, but did not show any differences from the structural changes from the MRI. Therefore, more researchers are needed again. Now, let's delve deeper into the mesenchymal stem cells-derived exosomes. These extracellular vesicles contain the bioactive molecules that can influence cell behavior and potentially promote cell proliferations and migrations, and have the property of the anti-apoptosis. However, the long-term result has not been validated. Despite these advanced treatments, research gaps remain. Given that OA is an irreversible condition, allowing to progress to the late stage can hinder the effectiveness of the treatment. However, initiating treatment in asymptomatic individuals may lead to over-treatment and diagnosis. So, the focus should be on those in the early stages, those who are symptomatic but without radiographic changes. Currently, there's a big gap in this area to facilitate the diagnosis in this patient group. The robust evidence and validated classification criteria are needed. This, in turn, will pave the way for studying the cellular mechanisms that occurs during the phase, ultimately leading to the discovery for specific biomarkers. The take-home message. It can be seen that the prevention of the OA progressions can be done in many stages of the disease. Therefore, do not wait for overt joint destruction to occur, because this will lead to the loss of native cartilage, which cannot be regained or returned. And for the advanced intervention, further evidences and researchers are needed. That brings the presentation to the end. Thank you for your attention.